I'll start off without introduction. I'll introduce. I am Dr. Minu Mathen. I am from Trivandrum Chaitanya Eye Hospital. I was in Aravind Eye Hospital before. Madhu is my good friend. He had invited me for last APOS meeting. I had a personal health issue, could not come. So I told I will 100% come for his meeting yesterday, night flight, overnight sitting, traveling, good. Anyway, good, nice to see. Thank you very much for the invite. So I've been asked to talk for 5 minutes on a 5-in-1 case. So please note, there is a little corneal haze which you can see there. Yes, it is corneal guttata. Shallow anterior chamber, you can see a PI there. And mid-dilated pupil, which is looking soggy, which is on tamsulosin, which is a hard cataract. In posterior polar, you will see it in a short time because of the hard cataract. So because it is mid-dilated, I know this is going to come down. So I am going to put my iris hooks, but not to dilate it more than 6.5 millimeters. That's enough. Now you can see the posterior polar. Now I turn on my retro illumination, you get a red glow. So I don't need to stain, otherwise please stain. No rexus, no good phaco. So no hydro procedure at all. So take out the cortex and epinucleus and now go in with my sharp tip chopper. This chopper has two sides, one is sharp and one is blunt. So I decompress the center and go into the mid nucleus and make my first vertical chop. So this is done without any hydro procedure. So one chop and then I go to the right side of it, one more chop. So one pie is free and it can be taken out of the bag and chopped and finished off. So you have some space in the anterior chamber now. So I now put on Oro coat, which is the equivalent of Oro viscoat, which is a dispersive viscoelastic, and I put HPMC in the center, giving it space for phaco to happen. And then I turn towards my left, do again one more chop. Go towards the right, do one more vertical chop. So no movement of the nucleus, but 1/3 of the nucleus is out. So no disturbance of the posterior polar cataract. Now I turn the chopper. Now I get my blunt tip chopper, go to the equator, support the nucleus in the trench with the phaco probe, and then do a cross horizontal chop. You get one more pie out. No movement at all now. Still again sweep along the equator and pull. Now almost half of the bag is empty. So gradually, slowly pull and pick the nucleus up and hold at the equator and chop. So you get one more piece. That is again emulsified, very controlled and endothelium covered with viscoat. And then now it is easy to pick up the whole nucleus into the anterior chamber. This is picking up and not rotating out. So that is what is the most crucial thing about a posterior polar. And see the control with which we should do slow phacoemulsification. The pieces should not fly around, should not hit on the endothelium, and should be away from the PC and from the endothelium. So in the center of the pupil, continue phacoemulsification in a very controlled way and exchange with visco. Do not withdraw and shallow the chamber. Now next thing is visco dissection. So to free out the epinucleus from the equator, I do visco dissection, but do not compress the anterior chamber. While doing that, keep pushing out visco also. Push on the posterior lip of your tunnel, and then I do mechanical removal of the epinucleus from the equator so that the epinucleus is all free. Now I go in with the epinucleus mode. That is very less power, and move all the epinucleus from the equator and come towards the posterior polar at the end. But now you can see that the posterior polar has slightly moved, but till now there is no vitreous disturbance, there is nothing, and I don't have any nucleus to drop now. So even if the PC is open, it is okay. You can deal with it without a nucleus dropping. Now you can notice all the peripheral epinucleus has come out, and now I don't need this phaco probe large open, because with this kind of an epinucleus, if you go in with the IA, it's going to take a long time. And that's why after finishing the peripheral epinucleus, I can exchange. Whenever you're exchanging irrigating handpieces, put in viscoelastic through the side port and then only exchange. Hyperinflating and shallowing the chamber in a posterior polar cataract is not good. And now I go in with my coaxial, or if you're okay with your bimanual, you can do a bimanual. And then there is no piece end now. Even if there is a piece end, you can manage a piece end. So this is the posterior polar being dealt with in a very controlled way. But till the end, the posterior central PC is weak, and now I am hydrojetting the posterior capsule. So still should not hydrojet the center. Many of these kind of single piece lenses I place under hydro. under fluid, but here I do not, because I don't want the chamber to shallow, or I don't want the IOL to hit the PC. The PC should be far away from the IOL placement when it is happening very gently. And then again, taking out visco. I had a PC rent while taking out viscoelastic, because you go in with your full fluid height, and then the visco which is inside again hyperinflates the anterior chamber. So burp out fluid, visco, and go in with your little lower bottle height. And that is the end of this case. Thank you very much. I am supposed to go ahead with another talk. Any discussion on this, please? If you want to have by the time I open.
When there is a...
Sir, excuse me, sir. Is there any preoperative assessment of posterior capsular dehiscence?
Oh, that is one thing which I wanted to tell in between, that every posterior polar I do anterior segment OCT nowadays. It's very, very useful actually to do an anterior segment OCT, because if definite openings you can see, but weaker areas which can give away with your manipulations you will not see. But open ones you will definitely see in most of the cases, and we have seen. And you should have VR backup, and then tell patient you may get a posterior drop of nucleus. See here, your support is very less. You are not like normal people, so you may take 1 hour. It may take more money. Vitreous surgeon should be required, and all those do in his room. And shifting a patient from one room and to the other may be clumsy, you know.
In equatorial fibers are there, equatorial cortical fibers are there. Do you plan to just rotate the lens when there is a jonular dehiscence? Or
I
you want to...
didn't get the question. If there is cortex in the equator?
Yes, exactly.
Rotate.
In Morgagnin cataracts.
Morgagnin cataract.
Yeah.
In Morgagnin cataract, totally different scenario. If there is Morgagnin does not have any this one. If it is a large nucleus, I will go ahead with the phaco.
The
but then if it is
part
small,
of the cortex, which is there in the equatorial, the technique for the residents, I would like to...
If it is a Morgagnin cataract, if you are resident, please do SICS. Do not do phaco. So if you have done 2000 phacos, then think about doing a phaco in a Morgagnin cataract where you do not have any support. It will be a free nucleus moving in the bag, and there is nothing behind protecting the posterior capsule. You will easily, sometimes inferior zonules also will be weak. So you will be pulling out the bag very easily. So using a capsular tension ring if that is required, and then you can place an IOL into the capsular bag beforehand. If it's a small nucleus, you can push it away into the side of the bag, or lift up the nucleus into the anterior chamber, implant a single piece lens into the capsular bag, push back the nucleus, and then do a phaco chop easily.